welcome everyone to the Clinical Design Group meeting. Thanks so much for making time for us.
Excellent. We'll have a chat after.
Before we start, just wanted to acknowledge the traditional custodians of the land on which we're all gathered today. Here in Brisbane, it's the Yuggera and Turrbal people, and we pay our respects to elders past, present and emerging, and extend our respect to all Aboriginal and Torres Strait Islander people, acknowledging the first people as the first scientists, educators and healers. So just a reminder, we are recording this so that we can put it on our website, and so please let us, if you don't wish to be photographed or videoed, please turn off your camera. So for the agenda today, we've got quite a bit kind of packed in here. We'll do a really quick AUCDI update, a short chronic condition management CFG update. We'll do a recap of the July face-to-face that we just had, but we probably won't go deep dive in the outputs as we're still working through that at the moment, but we'll give sort of a little summary of what happened. And then we're going to really dive into some of the data groups that we had identified as part of July, and work through some of the data groups so that we can start including those in AUCDI R3 and then work through the next steps. Just a quick reminder, AU Core and Australian Clinical Data for Interoperability. So AUCDI is really defining what that clinical information, that clinical requirements around what should be included for data entry, data use and sharing. And so that's what we're doing here in the clinical group. AU Core is the how the core data should be structured, accessed and shared between systems. So the technical design groups are working on the FHIR implementation guide for that. And so we work together, making sure that we understand what the clinical requirements are and feed those to the technical design group to take those, process them and add their own requirements around them to produce what they need to produce. Just as a quick update in terms of 24-25, I think for those who are new with AUCDI, we've released the two releases. AU Core, FHIR IGs, patient summary, e-requesting are currently in ballot. We've set up a whole bunch of tooling. So we really, I think we kicked a lot of goals in the last 2 years. So thank you so much to the community for your support. I think we together have managed to achieve like a whole bunch of things, and it has been very much recognised. I don't know how many people were at HIC last week. It was pretty amazing to see the health minister mention Sparked in the community and the number of hours that everyone has put in. So a big thank you to you guys. And, it is being acknowledged and recognised, and the Digital Health Agency and the department, they're all looking at how do we start embedding all of these things into their work. So it's very cool. So thank you.
I think it was mentioned in almost every session.
Yeah, I think almost every plenary had a mention of Sparked, the work that's being done, AUCDI, AU Core. So it was really cool to hear. Just a reminder, if people missed it, we did have a symposium back in May, and it was sort of looking at FHIR starting around the world, focusing then on Australia, and then looking at the jurisdictions, and then community showcases, speaking to some clinicians, looking at software, what the software is doing with some of the outputs of this, and kind of bringing it all together with looking at, there's all kinds of standards. So how does that all fit together? It was a really, really interesting day. And all of the recordings are online on our website, so on YouTube essentially. So if you're interested or have colleagues or friends who are interested, please feel free to send them the link. I think there's some really interesting things, like there's something for everyone in there, if you like standards or if you're interested in standards. And then we also did release a Sparked book, and it's really just a photo book just to kind of capture some of the feel of the last 2 years in photos. There'll be a bunch of you guys in there just to kind of celebrate what we've achieved as a community and who's been involved in all of that kind of stuff.
Showing how much participation there has been from everyone.
Yeah.
I think trying to demonstrate that.
Yeah,
definitely.
So that's all on the website there, and Maddie's put in the links on the chat. So thanks, Maddie. And the last other announcement that I had, Brett Sutton has hosted a second season of the Spark podcast. So you'll find that on like YouTube, on Spotify, wherever you get your podcast. But Brett Sutton's hosting again, and we've got Graham and Rachel Dunscombe from Open Air, Rory Davidson from SNOMED, and then a bunch of our community members. We've got Sanka and Kim and Kath and a whole bunch of people. So please check it out. We tried to kind of reach a few different topics there, whether it was aged care or specialist care, allied aged care, that kind of thing. So you can find that in the link that Maddie has popped there, or the QR code should take you there as well. Okay, so just a quick AUCDI update. We did publish it in June 2025 for just as a reminder, we have, I guess, matured from core to clinical. So it was previously called Australian Core Data for Interoperability, and that first release was really that core of the core. What is that really base level of data that kind of non-use case specific, but kind of supports almost everything. And as we added in last year, added in patient summary and chronic condition management, you could see that our scope was naturally growing. So it made sense that we wanted to kind of have a name that reflected what AUCDI includes. And so it really is that clinical information. And we wanted to make sure that we all know that that data needs to go across a patient's life course, across the health continuum, and across the health ecosystem. We know that a person doesn't just sit in one place the whole time. You're kind of bouncing between all of these things, and the data needs to follow through all of that. So we need to keep that in mind as we build out our data models. So the scope of AUCDI at the end of R2 is a lot expanded after R1. You can see the things with a square, the core things that we really focus on in R1, but the stars and the circles are where we included or added some additional patient summary and chronic condition management stuff. So you can see there's a whole bunch of social determinants of health and a whole bunch of new interventions that have been included and health behaviours, and we'll keep continuing to grow this over the next year. As some of you would know, release 3, we're continuing on the chronic condition management piece and looking at health assessments, scales and scores. We're also looking at an encounter record as well as the priority backlog items. So some of the items that have been identified over the last 2 years that we weren't able to address, we're starting to picking some of those off as we as a group have decided or asked for them. And I think this is just sort of the schedule. We are looking to produce AUCDI R3 in June, so like that 1 year cycle. And we do have a face-to-face in Canberra on the 12th of November. We are looking, just flagging ahead in February, to go to Tasmania. So I think we'll tick off all of the states and territories in terms of having Spark events, which is kind of cool. And then May, we will have another face-to-face, but we haven't locked in a location.
Likely to be Brisbane, though.
Likely to be Brisbane. Okay, and then the next update, I'll pass to Tor to just quickly talk about the chronic condition management clinical focus group update.
Yeah, and for those that were in Sydney, this will probably look familiar because it's just kind of wanting to make sure that we're sharing the same update with our online community with the face-to-face group. So just quickly a reminder of what the clinical focus group is. So it's essentially a group to be able to provide that clinical guidance and expertise to help build out the workflows, the data flows, and any other materials to support AUCDI and the FIRE-ING development. And we specifically with the chronic condition management clinical focus group, we're looking around the creation of journey highlighting the complexities of chronic condition management and any other considerations around that. I think as well, just calling out that for what we don't do in the clinical focus group, the data modelling and the AUCDI development still stays with the CDG, and the FIRE implementation guide development still remains with our technical design group partners. And also any policy discussions, any questions that come up around in regards to policy reforms, clinical pathway recommendations, implementations, funding arrangements, etc., they're not within our scope. We're specifically focused around creating examples to help support the work that we're doing in Sparked. So they're indicative and they're not meant to specify or recommend a particular clinical process or pathway. And also just wanting to call out that we do our best to give an indication across as much as we can of the healthcare system, but they're not exhaustive scenarios. So they're not going to include every possible pathway or clinical discipline, purely because it gets a little bit overwhelming and we only have so much space and time. Okay, so what have the CCM CFG been doing? So over April and June, we had 4 meetings and we started talking about the creation of a chronic condition management journey, what that should look like. And we rapidly evolved, as you can see there, in complexity for what we actually need to do for chronic condition management as opposed to what we'd done previously in patient summary. So where we started with the initial conversation with the focus group was using a similar sort of roadmap template to try and start building out a journey. But what we found was that that wasn't sufficient and we actually needed to expand and include additional detail. So we needed to be able to separate out the stages and have additional information in each of those stages. So we then sort of leveled up and we took a different approach. We restructured how we were going to represent the journey itself. So we added in a timeline across the top, an activity for each stage, and had different sections calling out the story and then trying to indicate who the care team members were and some of the opportunities at the different stages of the journey as well. We also then found that we actually needed to have some supporting materials, not just the journey itself, because when we started talking with the clinical focus group around what the actual journey needed to look like, we found that we also need to call out what some of those ongoing care coordination and management interactions were with the different parts of the health system, and also how the information and data would be shared and used across the different levels of the healthcare system as well. So we went sort of from having this initial very simple roadmap journey into a more detailed journey, as well as some supporting artifacts as well. So just quickly to reference, the ongoing care coordination and management diagram is to demonstrate those interactions between the individual and the core care team and the phases and stages of the care coordination with the different healthcare service providers. And this is still in draft. This is by no means finished. And similarly, with the primary to population data wheel, it was just to try and be able to show where the information that's collected during a patient's journey might be exchanged and used at multiple levels. And again, this is in draft. We still need to refine and land on a final version for these items. So then, going into what the chronic condition management journey looks like in a bit more detail. I apologise. I know that on screen it is very difficult to see, but just to sort of run you through what it looks like in the sections. So essentially on the left-hand side, looking at the screen, we've got a case scenario at the top, which is just sort of saying who our patient is and introducing them, very basic. And then the core care team members that are involved in delivering in this journey example that we have created. We've also included a section at the bottom to say that there are auxiliary extended care team members that may be involved at different points of the journey that we haven't specifically referenced, but we did want to indicate that it's not just this, list of those that we've included in this journey that support chronic condition management, but also this idea of having that extended care team that may, come in and out of a patient's chronic condition management over their over time, essentially. So looking at the centre of the journey, what we have across the top is a time frame. Again, just trying to indicate this is a 12-month snapshot we've taken of our patients' experience of chronic condition management post their diagnosis. And we've called out across the top the time frame associated, the stage of the journey, the activity, or like a sort of an overview, like high-level activity that's occurring at that stage. We've then got the story in detail for each of the stages of the journey. And then in the grey line, you can see we've tried to include or indicate the different healthcare providers that are involved in that stage of the journey. So you can kind of like have a bit of a reference point. And then also what the data and information artifacts are that may be accessed. at the stage of that journey. And then lastly, in the orange section at the bottom is an opportunities section that we've called out. And the opportunities we've sort of grouped under those that might be considered a patient empowerment opportunity, a data and systems opportunity for the immediate, meaning the next 1 to 2 years, and a data and systems opportunity for the future, which is meaning sort of that 3 to 5+ years. So it is very detailed. I won't read through the journey specifically, but just to give a quick overview, it's about a patient, Katerina, who's a 55-year-old woman recently diagnosed with type 2 diabetes. It's looking at the first 12 months post her diagnosis. It's focused on her experience of that. And we do want to really clearly call out that in the real world, it's likely that Katerina might have other conditions and other diagnoses being managed at the same time. But we, for the purposes of this example, just focused on a single condition, noting, I think when you look at this, you can see how complex it is, even just focusing on one. So we totally acknowledge and appreciate that this is in the real world, there would be multiple levels to this that are not called out in this journey. We tried to focus around highlighting a person-centered multidisciplinary approach and identifying some of the interactions that our consumer has with the healthcare system and different members of her care team, and how a chronic condition management plan may be used to help support that. So I think just keeping in mind when looking at this, it is an example only to help give us some context for our technical work and our work in standards. It's not meant to be prescriptive, a recommendation or anything like that. And we do acknowledge that there are many pathways that this patient could have taken other than what we've called out in this journey. But again, it's just an example so that we can have these conversations as we go. I think the last thing I just wanted to sort of show is that we've already used this, and those that were there in Sydney will be familiar, they will have had a chance to read it in detail. So we did actually leverage this journey at our Sydney co-design workshop on the day 2, where we were starting to think about what would be required to support a GP management, GP chronic condition management plan template in use, thinking about how we could build out the workflows associated with it, and the detailed processes that would need to accompany the use of a GP chronic condition management plan. So it was really great. We actually took different little cuts from the journey of the different healthcare interactions and worked through what some of the process and workflow steps would be. And we've, as you can see there in that bottom photo, we got a lot of great feedback from those that were in the group, and we're currently going to work through pulling the materials and outputs together from that. And I think last thing I just wanted to say was the next steps with what we're doing in the chronic condition space, and with the clinical focus group. We're going to publish that version of the chronic condition management journey on the Spark website. So everyone will have an opportunity to read it in detail and provide us any feedback as well. And lastly, we're just sort of looking at now what are the requirements for the next tranche of work, pulling together what the outputs are from Sydney and updating the remaining 2 diagrams. What are the additional materials CFG might need to assist in developing for chronic condition management in Sparked, and determining what any future meetings or workshops will be required with that group. So for those that are in the CFG, you'll probably be hearing from me soon. And then, yeah, obviously everything that we discuss and we develop, we bring back to this group as well. So yeah, bit of a quick update, but I'll stop there.
Thanks, so I think it's just a really good way that we can, like, it's just illustrative. It is also to help us give us common language between us and the technical design group. And I think it's great that we have so much detail because we're able to cut different perspectives out as we need. We use certain parts of that to look at the opportunities because we're looking at a technical roadmap, but if we're then looking at trying to understand processes, we're able to focus on different parts of the thing. So that will go up on the website so you can have a look at it. I think at the end of the day, we're not driving best practice. This is not about us promoting any particular workflow or treatment pathway. No. This is us just trying to get a common language so that we're able to communicate with each other and give context to some of the decisions that we're making around the data and data specifically.
Yeah.
Okay, so that was a good update. Now, I just wanted to quickly recap the 2 days in Sydney, and this will be a really quick one because I think when we start to go into detail around the outputs of it, I'll kind of go into it a little bit more detail. But the 2 days were held in Sydney. It was a really great 2 days. The first day was really focused around the AUCDI R3 scoping, and we had about 100 odd people attend. And then day 2, we were looking at the chronic condition management plan roadmap, so really focusing around those workflows and processes, and we had about 80 over attendees, which was really great. So that first day, we were really looking to understand the approach for AUCD R3 to modelling health assessment information. So that was kind of the focus of the first half of the day, kind of understanding health assessment information, what are the priority focus areas that we wanted to look at for R3, and then what data groups should we then include within AUCDI this release. We also wanted to look at the backlog and see what other priority items were identified by the community that we should then also try and include in R3 as well. So we had a few discussions, a few people provided us some context to where health assessments kind of sit within different professions. So we had a whole bunch of people. So it was really good in terms of setting up the context for us. So whether aged care, pediatrics, GP in aged care, allied health, nurses as well. So that was a really nice start. But it's kind of starting to think about all of these things and how they kind of start to all fit together. We also kind of we reviewed our core principles of data set design. So thinking about making sure that we are focusing on reducing duplication, so that single entry, multiple reuse. We want to support that person-centered care and not just collect data for data's sake, thinking about primary clinical data use, but considering secondary data use needs, but that's not our primary purpose. And we want to support best practice care, clinical guidelines and clinical workflow and align where possible. So when we talked about the health assessment information, it's kind of hard to think about like what is health assessment information. So we sort of brought up this framework here around thinking about health assessment information, and it's just a starting point for us to kind of start thinking about health assessment information within an encounter. And the way we kind of split them up was there's health record data or structured data that is the information or evidence that is collected as part of an encounter in your usual process of identifying risks or collecting evidence or making clinical judgments that you would then use in assessments. So some of these might be head circumference measurements, distance able to walk with aid or independently, blood pressure, things like that. There are also health assessment forms. So these are forms and templates that you required to complete in the process of delivering care. So whether it's clinical care, reporting, MBS and funding. So some of these might be like MBS, this Indigenous Health Check. It could be a comprehensive health assessment plan like CHAP, or it could be a smaller, shorter one. It does not need to be a full health assessment. But then there's also the validated health assessment tools. So those are the agreed formal assessment tools that are standardized, validated, and they may have complex algorithms within them, complex scales and scores. And sometimes these are proprietary. So examples of these are Inter-RAI, Bartel scale, the CVD risk calculator. And we also recognize that there's health assessment information across all the in all of the domains, in all of the different parts of the health system. So it's kind of a ubiquitous thing that's being used within health. So then we needed to think about how do we start to capture this as data groups and things for within AUCDI. So we were thinking, how can we approach this? So for us, we were thinking there's 3 different ways of starting to think about data groups that we could start to think about. So firstly, a data group just used to track the status of each health assessment intervention. So just knowing that an MBS 715 was done, or a diabetic foot check, or an Oxford knee score, knowing that that was done and a date associated with it, is that useful for exchange for care. We also want to think about health assessment information as reusable data groups to capture health record data. So things that would persist within an electronic medical record, things that are captured as part of routine clinical care. So some of these weight, height, head circumference, blood pressure, medications, activities of daily living. The third kind of group of things that we could look at modelling was around modelling the assessment tools themselves. So one data group per score or scale or questionnaire. And for example, like modelling out Bartels or Audit C. What we would like to do for AUCDI R3 is to kind of, as a first step, include a data group so that we can track the status of each of the health assessments. So that we're able to at least know that they exist and have a terminology that supports them. So to know that it's been done, and eventually look to include perhaps in the future, like being able to note when it's being scheduled or planned to help support other care flow steps. And also look at creating some more data groups to capture data that you would use within the health record. So additional ones to support aged care, pediatric care, other things as well. So some of those other things like head circumference or perhaps distance, activities of daily living. We do recognise there's a whole bunch of things that we could possibly do around specific assessment tools, but perhaps for our first release, we focus on the underlying data groups, but using some of those assessment tools to help us provide the scope. So what I'm looking at, and then I'll ask for any questions in a second. So the approach that we recommended or that we put to the group was to include data models to support that recording and exchange of health assessments that are being carried out. So that assessment name and a completion date, and to support the recording and exchange of health data, health record data for use in assessments. In the future, we will look at specific data groups for health assessment tools, and also look at which ones are priority that we should look at modelling in AUCDI. I don't know, did Oliver have a question in there?
Yeah, so Oliver's just asked, does assessment imply that we're comparing data that we collect about a person with some norms or population data for people of a similar age to decide whether the person is better or worse off than others?
Yeah, and I think that's where we were trying to sort of say that an assessment could be something you just do within your daily practice because you're making an assessment or taking a measurement or making a judgment. But then there are also those validated health assessment tools, which then you can be using to compare across population, across different things. So yes to both. I think you've got your hand up. I can't see. Sorry, Oliver.
Yeah, thank you. That's what I was just trying to think what's different about assessment from just collecting data.
Yeah.
So we can measure their height and their weight and so on, but that's just data. And so that's what I'm saying. I think assessment implies some judgment, and the implication is it might change the care that we provide or that we think the person needs.
I agree with you, Oliver. I think it's just the words are used a little interchangeably, and so there's not really, like, while it may be an accepted definition in like one place, in other places it's sort of a little bit more open or vague. So I kind of wanted to try, and this was something that we built ourselves, this sort of model, to try and tease out the differences. And I know it's not perfect, but it was just somewhere to start to kind of try and have these kind of conversations. So yes, I totally hear you. Thanks, Oliver. So we do, just as an aside, we are keen to know if you have a list, or if you're a vendor software and you have a list that you've implemented, or there's a whole bunch of tools and forms that you use. If you could send us those, we're kind of trying to crowdsource that list because we can then go away and kind of do our own research. But if you have lists of tools, validated or like commonly used, whether it's your business policy that you use these things, we're really keen to kind of understand what that is and what the breadth of it is, so that we can kind of see what terminology is needed to support it, and looking forward from there. Just checking. We did discuss this as a group, and there weren't any objections to sort of taking this approach. So we might start with this approach for modelling health assessment information, but we'll probably talk about this a bit more in detail at the next meeting, because the other thing that we did talk about in that workshop was where should we start to focus our efforts. what health information, assessment information are we interested in, and what are the priority data groups that we want to include. And we've only just started looking at the data that's come out of it, so we'll probably go into more in-depth next meeting. But really, the things that were identified were quite wide-ranging, from women's health, aged care, mental health, social determinants of health. There was this whole focus around transitions of care, which really makes sense, looking at pediatric information, functional assessment, lifestyle risk factors, cognitive assessment, First Nation health assessment. So we're going to have a look at that and come back to you guys with a proposal at the next meeting. But there was this real strong support for that idea of cradle to grave approach, that we really need to make sure that the data supports all purposes. And I can see your dance, Kim. So we will bring this to the next meeting when we have kind of synthesized and like brought a proposal out. The other activity that we did was a community prioritization of the AUCDI backlog. So we put out an EOI to see if there were interested members of the community who wanted to pitch to us what might be of high interest to the clinical design group, and kind of give a proposal to the group on the day that we should include certain things in R3. So we received quite a few, so that was quite amazing. It was a really interesting part of the afternoon. We had different members of the group. So thank you so much to everyone who presented to ask for different things. So there's some things around blood pressure procedures, heart rhythm, adverse reaction risk summary, head circumference, vaping device, and about me. So after each of the presenters presented, they were given a 5-minute pitch slot. We got the tables to think about what is their top 4 priority items that they think we should include in R3, and voted. And you can see there's a pretty good spread, but it was interesting because we also asked for commentary on paper to understand why people pick certain things. And it was interesting that some of the comments around it was around no-brainers, or things should just be included, and they didn't actually vote for those because they thought, well, since it's obvious, we should just include it. There was also commentary around how things that are quick wins and low effort should just be included anyway, so they hadn't voted on it. So on that kind of note, we wanted now, because of the things that were presented and how, I guess, evenly the votes were spread across the things, we are going to try to attempt to include as many of these 8 things as possible. So that's what the majority of this meeting will be once I quickly finish this part. There are 2 things though that we do need a little bit more thought around, so we won't be presenting a proposal at this meeting, but we will endeavour to get it into R3. That is about me, because we want to make sure we need to involve the right people and see what other work programs that are happening, what are they looking at, and making sure we align. And in terms of procedure, clinical outcome, we do need a little bit more thought there. So we will kind of get back to you at one of the future meetings. Really quickly, before we dive into the data groups from the backlog, we did also have a day 2, which was more of a design meeting, and we had updates from the Department of Health, Disability and Ageing on the MBS Chronic Condition Management Framework and assessments. And we also revisited previous work that we've done as a CDG around the GP management plan and chronic condition management plan. So what we were really trying to do that day was understand the clinical and technical requirements for a chronic condition management as a GP management plan MVP that we were looking to deliver by the end of June next year. So a really short first step. But also understand, like, what's the roadmap, what's the desired future state of the chronic condition management plans to kind of support consumer empowerment, multidisciplinary team, and really what enabling digital infrastructure do we really need, and thinking about it all within that sort of greater ecosystem. If we start having patient summary, we've got e-referrals, we have encounter records, how do all of these things kind of come together? I don't have any, again, we're still working through, there was a lot of information that we collected. You guys provided us with a whole bunch of things, and so we're kind of working through that at the moment. But the themes really that we all agreed that structured coded data was essential, but it has to be usable. We need to make sure that team care is effective, and that only happens if tech supports that shared access. Patient goals and values are really important to all of this, and we need to bridge that everyday practicality and clinical rigor. So we will provide more detailed outputs and actually probably talk a little bit more about them at a future meeting as well. So that's kind of the update there. I think for time, if there's any questions, feel free to put them in the chat. Oh, I've got one question. Alex, did you want to ask a question?
Sorry, I accidentally clicked on that. Sorry for that.
Oh, no problem. We will be putting, I think the slides from the day are already on the website. We are still working through the outputs because we've done a sort of first pass transcribing all of the content into a digital format, but we are working through synthesizing it. Once we have stuff, we will put that on the website as well. But we'll also present it back to you guys as well. So I might, if you have any questions though, I think we're kind of short of time, so I will pass to Nai in a second. But if you do have questions, feel free to reach out. You can pop some questions in there, or we can send us an email as well. So Nai, I might pass to you to kind of work through some of the data groups that came out of that community pitch fest.
Yeah, hi everybody. Thanks, Kylene. You can see on the slide, you guys had a great time in Sydney and going through all of these different data groups and discussing them. On this slide, we're talking about the ones that were, as Kylene mentioned, the quick wins. So those that are on the left, in the left-hand column, which say update, they've got some updates that have been made to the data groups, and some that are new. We're going to be working through those proposals this afternoon. So this is just a guide, and we've just reordered them so that we can sort of get your feedback, have a discussion, and move through the ones that were probably no-brainers through to the ones that need a little bit more conversation. So next slide. Okay, so the first one was blood pressure. We know that blood pressure data group has been previously published in release 2 of AUCDI. And then for those that are on the call that don't or haven't been or not familiar with the coding, you can see that blood pressure down the bottom has an orange data group highlighted around it. And we've also included the blood pressure roadmap, which is highlighted in blue. Now, there's only one data element that was proposed for blood pressure, and that's body position. So as we move through this, this process of what was pitched at the community backlog pitch, we're going to provide you with a description. So it's important that that's clear and unambiguous. And so here we've provided that the body position is the position of the individual's body at the time of measurement. And we prefer that it be coded with terminology where possible. And what we're trying to chase there is things like, was the person standing, sitting, reclining, lying down, or lying with a tilt to the left? So in that case, it might be for someone who's pregnant or in the last trimester of pregnancy where they were wanting to relieve that arteriocoval compression. So on the mind maps, you can see in the data group itself, the body position falls under the state attribute, which you can, if you go to the next slide, Kylene, sorry, you can see there it's been circled in blue. And on the roadmap, we've got body position also circled at the top of the state group. The data elements that are for future candidates are the ones that are appearing in grey with a grey flag, and you can see that this data element body position has an orange, a white star with an orange background, which indicates that it's a candidate for AUCDI R3. Next slide, please. Okay, so we are now reaching a point where we need you to vote, and we're going to jump to a Menti to be able to do that. So before I do that, has anyone got any questions around this proposal for blood pressure as we move forward through and start building out AUCDI R3? Yes, I think Rob has got a question. Yep.
Yeah, just clarifying, I'm assuming this blood pressure is being taken in the upper arm, and if there's nowhere that you can mention that, because occasionally we will take blood pressure well, and some of the recordings that we get from patients may be inappropriately done, but done anyway at the wrist with some of the machines that they buy. And then when they're in various ICUs and things, they may have different, I assume, taking blood pressures in different parts of the body. So it may be the leg, so I just wonder whether we should have a default position of this is the upper arm that it's taken.
Yeah, that's a great question. For this particular clinical requirement that came through from the backlog, we're just looking at body position, but you can see on the blood pressure roadmap there is a location of measurement that's been highlighted. Yep. So, and that's one of the future candidates. So we can come back and revisit that.
All right, thanks.
Yep.
Tony?
The size of the cuff, if the cuff is too small, you get a different reading. Also, the amount of time standing. If you take a blood pressure when they first stand, you'll get a different reading to if it's after a minute or so. There are certain criteria for what's regarded as the appropriate time after standing to determine whether a person has a blood pressure that's too low. So that helps to make sure that it's done the right way.
Okay. Yep. So we do have cuff size under the protocol. It's the first data element. It might be a little bit difficult to read. We're just trying to highlight that on the screen. Yeah, that's great.
Okay, right. Thank you.
Yeah. So then that's a valid point when you're taking a blood pressure. Absolutely. But that's one of the future candidates and wasn't pitched at the backlog pitch in Sydney. So at the moment, we're just considering body position, but we can revisit cuff size in the future if we need to. In terms of the time standing, there is a confounding factors, which is referring to the position of the patient, but I'm going to defer to Heather to just explain where that might sit. Heather, would you mind answering that question?
Yeah, sure. If we can zoom out again, Kylene. What you're pointing out, Tony, is really true. Being able to compare someone who's standing and getting postural drop with someone who's sitting, we need all of that kind of thing. The model that sits behind this from Open Air Archetypes allows for that using these events that are down the bottom. The any point in time event can be specified to be, this is like in an implementation, you could say this is the baseline when they arrived in my room, they've just run up the stairs, and then I'm going to do it again 10 minutes later when they've settled. And you could record them separately and it would be able to separate them out. So it's, again, in the roadmap, it's embraced in all of that because that is typical clinical practice, but it's not overtly revealed and it's not been prioritised at this point by the clinicians. So we can certainly have that as pictures in the future. The model allows for it. We can put that into our clinical requirements using that. And we'll see that a little bit later when we start to talk about like birth events as typical events of different times when you record things. And Nari is going to be presenting that on one of the other data groups, but it's complex, some of this kind of stuff, and we have to manage all of these kinds of things. This model is in fact designed to be able to take multiple blood pressures that are being done by the machine that goes beep in ICU, have a time series as well. So the 24-hour average event is there potentially for us to create a diagnostic blood pressure measurement for when you've got a Holter monitor on and you actually want to say they're hypertensive or not. That is one that we've specified and put into the standard, but whether it's baseline and then 1 minute later or 5 minutes later or 20 minutes later, there's a lot of flexibility that has to be done there and has to be done at implementation kind of point of view. So yeah, there's a little bit of movement in that, but it's certainly considered in the model. Thanks.
Heather, do you mind also just explaining what method means in this?
Off the top of my head, that is whether it's by machine, whether it's by palpation at the wrist of an ambo through the window of a car accident, something like that. So it's those kinds of things, how you actually go about doing it. But I'd have to look at the value set and the descriptions. I think that's the only method there. So that's about, yeah, is it the automatic cuff in the bathroom at home, that kind of thing.
Thanks, Heather. If there's no more questions, I think based on the requirements that we got from the community at the last one, we were looking to include body position, which is what Nai's just proposed. So if we could go to menti.com, there's a QR code here, or it's menti.com, and then the code is 19077436.
Okay.
Are you happy for us to include this in AUCDI R3 as we've proposed it, knowing that we do have a roadmap, knowing that we will eventually add additional bits to it as we need, as we kind of work through requirements?
We've got 55 people.
I will give everyone a minute. I hope everyone's got the QR code now. Got a few thumbs up, quite a few agree. And yeah, thank you for everyone who's popping in all the tools and forms. That'll be really helpful. We'll collate them all and add them to our list. We have received a few lists from some members already, which has been really helpful, and we'll just continue to bring them all together. So I'll just give it another few seconds for people to vote. I wonder if I can do a timer thing like the technical design group does. I have seen it somewhere. Oh, yeah. I can, but I won't. All right, so I will close it in 10 seconds. Okay, awesome. Well, it looks like we have agreement, so we'll look to progress with that one. And I'll pass back to you, Nai.
Okay, thanks, Kylin. Okay, so on the screen, we've got our second data group that's got an addition that we need to talk about, and that is the data element of regularity. Now, if we circle back to the guide that was originally proposed at the start of the backlog pitches, the actual pitch that was presented in Sydney was around heart rhythm. And we talked about it amongst ourselves in the Sparked team about what it was that was really needed in this particular requirement here. And the value set that was proposed was regular or irregular. So we already have a pulse data group that's been previously published. And I think it's really important for us to have a little bit of a discussion around pulse versus the heart beat, and we know that they're different clinically, but we kind of felt that this was where the regularity data element and that proposed value set would sit quite nicely because it's already nested within the pulse data group. So next slide, Kylin. You could just, yep. So you can see that we've got regularity sitting just under rate, which is around, you know, when you palpate a pulse on an arterial site, you can actually feel is it regular or irregular, and that we would then have a discussion at a future time around heartbeat and what those requirements might look like for when we're actually gathering the heartbeat as opposed and distinct to heart rhythm, which is something completely different as well. So if we go to the next slide, we've got our second proposal up, which is that we're going to focus on the published pulse data group and include the proposal to include regularity, which is around that consistency or variability of the pulse beats. So we'd like to code with terminology where possible and to propose the value set of regular or irregular. Yes, Tony.
Yeah, the pulse usually varies with respiration, so it is not usually completely regular. If it is completely regular, it is almost certainly pathological. So I understand that what we're really looking at for is something like atrial fibrillation, which is quite irregular usually.
Yeah.
So I think the terminology is confusing. And in fact, 2 cardiologists missed that particular problem with my heart rate. So it
Right.
shows that it's not well understood. But I think it's important that if irregularity is not the right word. It has to be varies normally with respiration, something like that, to distinguish it from what is other irregularities.
Okay. Kylene, did you have anything you wanted to say back to Tony's
Not to
comment?
Tony's point, I do think, I mean, we were talking about this earlier around like the clinical interpretation and clinical description around, you know, the other things that need to be recorded or does get recorded, and that's the interpretation of what the rhythm looks like, which does take into account other factors. So what was proposed was regular, or, and I think, yes, to Rob's point, the irregularly regular or regular, whatever the combination is, that those are actually what is of interest to like GPs and other clinicians. So Tony, I don't have much more to add there. I don't know if Heather, you've got anything that you want to bring up in terms of respiratory.
Look, I think Tony's point is correct from an academic point of view, and it is always variable to a degree, but in practice, the clinicians are recording whether something is obviously abnormal or not abnormal, whether it's normal, sorry. So the variation, I think, is taken, and that's part of the modelling that we're doing. We're trying to document clinical practice, not necessarily what the correct definitions are, etc. And I think this is a tricky kind of thing. The notion of being regular implies that it's within normal bounds. That's what we're saying, and maybe we need to define it as such and make that better. But I don't think we need to go into this physiological definition of it changes with respirations. I think that's just getting into too much detail that is not typical clinical practice. I think we need to be careful there. The notion of irregularly irregular and regularly irregular is valid, and it is something that we did discuss, and it can be something that can be an extra data element that could be added. It's tricky whether we add it as a single value set and allow people to be able to pick any of that, like in that chat where you've got, well, you don't want the fetal heart one in this one, but having regular and then the 3 variations in blue that are related to irregular is tricky. I think at the moment we've kept it simple, and maybe we can agree with that as a starting point. And if there is a strong feeling, certainly investigate further how best to identify variations in irregularity. And that's certainly, I think, something that could be added to this, and it can be displayed in a single value set on a user interface without any problems, even if we have separate data elements, but we can certainly explore that further. Is there anything else I need to clarify there?
Patrick has his hand up.
Yep.
You can hear me okay?
Yep.
So sinus arrhythmia is actually what Dr. Tony, I think, is speaking about. And we don't consider that abnormal, like an EEG, an ECG, I should say, would put that in. So like Heather is saying, irregular, regular, then sinus arrhythmia, we don't even mention it because everybody has it. So I think academic point it is, but clinically, I don't need every day. When I'm describing pulse, I don't really need to say that it exists or doesn't exist.
Thank you. Tony?
Yep. We have a lot of prescribers of GLP-1 agonists. One of the contraindications of that is gastroparesis. One of the perhaps signs that is not well recognized is the loss of sinus arrhythmia. So we have, and people have died from being prescribed these medications.
So how is sinus arrhythmia? How is the loss of sinus arrhythmia diagnosed?
It is diagnosed by a loss of that irregularity.
On ECG or on palpation of the...
Well, it'll be more likely on ECG, but the point is, if people are prescribing these medications, they have to be sure that the person doesn't have early onset gastroparesis, and that is one of the more typical signs of it.
In order to record something that's a sinus arrhythmia present or absent and it needs to be diagnosed on an ECG, we need to reflect that in the ECG model, not in the palpated pulse model. That's where I'd suggest you do it. This is not something that the average clinician is going to be using to diagnose.
Yeah, I think Adrian makes a good point in the comments that they use pulse as a screening tool, and if an irregular heart rate is identified, then further characterization is required, like through an ECG. So it would make sense, like what you're asking for makes sense, but not for this model because the model is focused around pulse.
Okay, what you're saying is that this model will not detect it, but the point is if you've got people prescribing these medications, they need to do something. There needs to be a way of highlighting the fact that people are being prescribed these things inaccurately. And so, yes, there perhaps needs to be a reminder to say a person is diabetic, do an ECG.
So, Tony, that is a really good, that's a good reason for us to propose having an ECG result being able to be recorded appropriately. And we have one that is incredibly extensive and allows the conclusion to be able to say what you're looking for. Sinus arrhythmia is absent, would be able to be recorded as part of that. But as part of general clinical practice, which is Pulse is actually doing, this manual physical examination of taking a pulse, I think it's out of scope for this particular model.
Yeah.
So we need to look at how to create this whole ecosystem so that all of this that you need is provided, but this is where we're starting. So ECG would be something on the backlog.
Yeah, it definitely is. Patrick, you've got your hand up. Was that a residual? Oh, residual. Okay, perfect. Thank you. So I've got no more hands up. So I might move to the proposal and see where are we happy to add regularity. We can revisit the value set. So I'm mainly looking at the model. Is this a good starting point for what we want to include in AUCDI R3? Heather, do you want to leave, or Heather and I, the proposed value set of regular, irregular, are we proposing that now, or are we re-looking at it to see the regularly irregular and the other version, irregularly irregular?
Yeah, it's hard to say. You all know what we mean. I think it's safe to vote on this at the moment, but if you want to have the extension, to have the extra level of detail, we can certainly investigate the best way to represent that and either add it to this value set or to add it as a separate data element in a future.
So if you, wrong one, sorry, please don't vote on that one. Yeah, please vote on this one. So this is the update to Pulse to add regularity. Do you remember how many votes we got in the last one? About 20, wasn't it?
I think so.
I'm going to try the timer thing. I'll give 30 seconds. Too long. I'm just going to let people continue to vote for another little bit, maybe 10 seconds. Any last takers? All right, looks like that one has passed. We will look into the value set a little bit in more detail, but we will include AUCDI in AUCDI R3 Pulse as proposed. So back to you, Noi.
Okay, thanks, Kylene. Okay, so now we're going to move into the adverse risk reaction summary. And what we've done is popped the concept description, the purpose, and the representation on the screen for everybody to go through and just have a little refresh. These descriptors or definitions were put on the AUCDI R1 and R2. So we've actually been able to define them and they were accepted by the community for the publication. So you can see that what we're talking about here is the propensity or the undesirable idiosyncratic physiological reaction unique to an individual to triggered by an exposure to a specific substance. And then nested within that group, we've got the actual event. So the event adverse reaction event summary is that little group over to the right-hand side. And once again, we've got the data elements that have been published indicated by the green circle with the white tick and the orange background. And the ones that are being proposed or proposed at the backlog pitches are the white data elements with the orange circle and the white star. So this particular data group, I mean, everybody is happy with that. We'll move to the next slide, Kylene. So the proposal was to include 3 data elements at the top level, which is the adverse reaction risk summary, and then 5 elements or 4 elements initially at the adverse reaction event summary. So next slide, Kylene. So the ones that were included on the adverse reaction risk summary were a verification status, and then criticality, the date and time of last reaction. And you can see that that's still in the nested, that's a parent model, the data group there. And then per reaction event, the proposal included a specific substance, so knowing exactly what the substance was that was causing the reaction, the onset of reaction, the initial exposure, and the clinical management description. Now, we've also added in the comment into the adverse reaction event summary because we felt like that there might need to be more space or more details about the specific event that clinicians would like to include or have recorded. Yes, Tony.
Yep. Mike, at the moment, it looks as though it's just one reaction. People may have more than one reaction. One reaction may be relatively benign. The other one might be quite serious. But here, I'm not sort of seeing how you differentiate those.
Yeah, that's a great question. And you're quite right. They might have. Do you mean for different substances or for the same substance?
For example, there may be a sleeping tablet that causes slight confusion, but might also cause severe vomiting
at another event. Yeah.
Or they might be happen at the same time. But I know from a coroner's case that somebody has died because the first reaction was put in, but not the second.
Yes. Yep. That's a really good comment to make. And if you can look at the, I'll just draw your attention to the adverse reaction event summary with the little 0 to star little label sitting nested underneath it. Can you see that just under there?
Yep.
So you're quite right that there are times where the same substance will have different reactions and we need to record every individual event separately. So that little cardinality indication is a technical term that we use to be able to say, yes, you can actually record this over and over again because each adverse reaction event will be different and they might have different details that we need to record in it. You're quite right. So for that reason, we can actually repeat that over again, but it's falling under the same parent, it's nested within the same parent group.
Thank you.
Yeah. Okay.
And by that same token, you can record many manifestations per event because you might have a rash and a cough or whatever it might be. Yeah.
Yeah.
I think Avril, oh, you've hand down. Okay.
Oh, good. Nari said what I wanted to say.
Okay.
And
Great.
June has a question, would any of these fields be compulsory?
The only one that's compulsory at the moment is if you can zoom in, Kylene, at the top. Can you see the one-to-one
Not easy.
substance name? But I'm going to defer to Heather. That's the one we've indicated needs to be mandatory. And I think Heather wanted to respond to that question, so I'll hand over to Heather.
No, that was the immediate response, but we're creating data models here that are agnostic of any particular use case. So the only time it makes sense to make anything mandatory is where it's universally applicable. So in this situation, if we haven't got a substance name, it's useless recording anything else in that particular model. However, in a particular use case, in a particular hospital or a particular clinic or an application, other things can be made mandatory depending on the clinical situation. So there's two levels of modelling, if you like. This is the universal one that becomes our standard, but we allow clinical flexibility. So if you do need manifestation to be recorded in every single situation, which makes good sense in pretty much everything, but not necessarily always, you would make it mandatory in your use case. So this is where the clinical systems or the IGs that come out of this will be making other things mandatory where it's clinically appropriate.
Danielle?
So I'm just looking at, because some of the terms there around onset of reaction and initial exposure. Are these dates?
Yes.
And so this is per reaction. So I think I'm a bit struggling with, I guess, in an AU-CDI context, if we know when the reaction event is, what do we mean by onset of reaction for a specific event?
You're wanting to actually understand when the first signs of the reaction started so you can compare it to the initial exposure to the substance, those kinds of things, so we can see reaction times, those kinds of things.
So we're thinking that clinical systems will have tracking in them that if we have, I guess, if we talk about exposure for a particular substance, then we might say we know that they were administered this at 10 a.m. and then we saw hives or a rash at 11 a.m. That's kind of the thing that you're expecting to see.
That's what the Allergy Council are asking for, yeah. And that's come from other clinicians as well. This was in the model before the pitch as well. So it's something that's been long-standing. Yeah, it's exactly what they're looking to do. And it helps determine if it's a true allergy or not, or whether it's a side effect or whether there are other characteristics of it.
All right. Thanks for clarifying what the intention behind those two labelled terms are.
Thanks, Danielle. Adrian, you've got your hand up.
Yeah, so we sometimes have patients who present with an allergic reaction. It's not entirely clear as to what the substance name that caused that particular reaction are. So they may have been exposed to a number of different substances and we're not exactly sure which one is causing the reaction. But they've definitely had an anaphylactic reaction and we need to be able to provide them with adrenaline in the event that they come into contact with one of those particular substances that may have, what do we do in that situation where there may be multiple substances that have caused the reaction, but we don't know which one it was?
What would you normally do at the moment?
At the moment, I'd put in an allergy, I'd say anaphylaxis, and I would put a comment field as to these are the number of possible things that could have done could have caused it based on the history.
Yeah, so I think this is tricky because if we don't have a substance name, we've got an allergy to something, and it's really not terribly helpful from a decision support point of view. If you've got a number of substances, my recommendation was you'd put a record in for each of those substances, but they're unconfirmed. So that verification status remains unconfirmed, but it will trigger every time you go to prescribe something like that and you've got manifestation of anaphylaxis. It's a high criticality and it will try and stop you prescribing it. And it will trigger you also to potentially get the allergist to check it out and so you actually know what it is. But I think, I mean, you can put that you've got anaphylaxis into a problem list and you can write a note that these were the kinds of substances. And that's a valid way of documenting it as well, but it won't drive decision support when you go to prescribe. So I'd suggest you actually have to create a separate instance of each of these reaction summaries for each substance that you think might be causal until you actually do the detective work to actually say, actually, this one's not appropriate, we'll take it out, and this is the one that remains. That's the precautionary way I'd suggest that you do it, but other people might have other opinions. That's really the way this is designed, because if you don't have a substance name, you cannot do the decision support. So you could do both. You could have a problem list and multiple substances that are unconfirmed with a manifestation of anaphylaxis. I think that's valid.
Thanks.
No. Was there more that you wanted to talk about on this?
Yeah, I think if we just go to the next slide. So we've just added a comment in which we've described there. On this slide, I'll give people some time to have a read about the definitions, the concept definitions for each of the data elements. And there we've proposed some value sets. So, for example, we're proposing at that top level to add those 3 data elements in. So, as Heather said just previously, verification status, criticality, and onset of last reaction. And for verification status, we've got a proposed value set of unconfirmed or confirmed. And for criticality, we've got a proposed value set of low, high, or indeterminate. Are there any comments about those particular descriptions that we've provided there on the screen?
Do we have a definition of how confirmed and unconfirmed is going to be established? And does that mean they've had skin prick testing or something?
Heather, did you want to answer that question?
It hasn't actually. I mean, it's something that I think this is kind of the role of groups like National Allergy Council should probably be determining as best practice. Their words are, I think, related to confirmed and unconfirmed, but yeah, how to do that is out of scope of AUCDI, but I do think it does need to be added as a thing. And I think, I would love to see the Allergy Council be working alongside this to support this kind of documentation about what is best practice, what these definitions should be, so we're doing it consistent.
Yeah, thanks, Heather. Avril?
Yeah, I just popped a screenshot of Fire International. They've also got the refuted verification status, which we were talking about having an allergy to an unknown substance, but it's one of the 3. And then you've got to remove that allergy. Should we think about including the refuted status as well here for that use case?
Yeah, that's a really good question. Refuted is basically when, it's really important if you're sending a message. So if you send a message to someone else and you've said that there's an allergy and then you actually say, oh, well, no, it's not. In a clinical record, you can actually just remove it from an allergy list. And formal documentation of delabeling is something that we want to work through with the National Allergy Council as well. They've raised it as a really critical thing, and I don't think there are good lines around it. How to do that properly within a health record, I think does need to be included here. I'm not sure if verification status is the place to do it. From a messaging point of view, refuted makes sense and also potentially entered in error, but it works differently within the electronic health records. So I think at the moment, let's start with the unconfirmed and confirmed, and we can get further guidance as to how that might need to be extended or whether we document delisting and kind of messaging in another way. But I think this is a good starting point.
Yeah, I think the other situation, I guess, is that, someone's put on an allergy and then it's been refuted, but then the patient or the carer still reports the allergy. So it's useful to have that history to say, oh, actually, yeah, but how we document it, yeah, remains
That's
the same.
what I'm getting at is we need to record the delabeling properly. Yeah. And I'm not sure that just recording refuted and verification status is adequate. Yeah. But I'm happy to be guided by people more expert than me, and I don't know what that looks like at the moment. I think this is a safe starting point. We can always add to that value set if we want to. If we add something and then decide it's not appropriate, we are breaking changes if we remove it. So I'm reluctant to add it in just in case. I would rather do investigation with people, but understand that AUCDI, while it's going to feed into the fire IGs for use in messaging, it is actually about what the clinical requirements are for our electronic health record. So there's a slightly different use case, and we need to look at how to manage that, communicate it, and document it appropriately. It's a totally important point. Delabeling, I think, is really quite daunting to me. So that's where we need to do some serious investigation about how best to represent it. And I haven't seen it done anywhere else in the world. So we're right at the cutting edge of that from our point of view. Deborah.
Yeah, sorry, before you just go, I was just going to say that this was developed with the National Allergy Council, and I do believe the National Allergy Council is part of ASCIA, but definitely happy to engage with whoever needs to be engaged with. And I do know they are doing a lot of work around the delabeling at the moment. And I think they've got some papers that they're working through at the moment. So we're definitely keen to kind of make sure that we align and make sure we're all going in the same direction.
Yeah, I'm trying to say that we're working with the national experts, but I'm
Yeah,
reporting
for sure.
on that wrong group. My apologies. It's absolutely looking at people with more expertise than me.
Yeah, definitely. Deborah.
Hi. So I just want to, is criticality basically what we would have previously termed as severity? In most, like, is it the severity of the allergy or adverse reaction?
Well, severity is tricky in that it gets used interchangeably. So it is the severity of the propensity for an adverse reaction to occur on exposure in this situation. You can see on the right-hand side of that mind map, we've got severity of reaction. That's recorded. So that's trying to give some indication of whether it was life-threatening or mild, etc., of overall reaction, all the manifestations. So if we're talking about severity of each reaction event, that's where you record severity. But if we're talking about, like, if criticality's got values that we're proposing of high, low, and indeterminate. If you've had any kind of allergy, we're suggesting that low would be the default. You can see that in the italics text above the value set there. And if you had anaphylaxis, you'd be suggesting it should be high. If there's something that is life-threatening, anything that's not low, then it should be recorded as a high, basically. So it should trigger another level of decision support if we were doing this smart. But I don't think any systems are actually using this at the moment. It's something that's been historically used through a lot of the HL7 standards, and it's used internationally, as I understand it.
Yeah. Look, I'm doing some work around our allergy capturing in Victoria, and our information sharing platform has the ability to record the severity of the allergy and also the severity of the reaction. Now, we don't tend to get reaction severity, but we do tend to get allergy severity. So I'm just trying to make that. So in my mind, criticality is the allergy severity, and is criticality what the Allergy Council requested?
Yes.
Okay, no, that's good. I'm just, I'm trying to align my platform and standards with what's going on, and I'm happy for that input. Thank you very much for that clarification.
Cool. Thank you.
Were there any other hands? There's no more hands. No. Was there additional things that you wanted to mention?
I was just going to mention that we have provided definitions for the 5 data elements, which are on the right-hand side, that are nested within the main data group of adverse reaction risk summary. So the ones that have been provided or were pitched at the Sydney event were specific substance, onset of reaction, initial exposure, clinical management description, and we've also popped in a comment just because we felt that there might be some need to provide additional details about the specific adverse reaction event that needs to be recorded. And those definitions are on the screen as well. So just, I think there's a hand up, Kylene. Sorry, I can't see. Kelly. Yes, Kelly.
You want to finish your line of thought first?
Oh, I was just going to say there's some definitions there to consider. Because the slide's quite busy, I'm not going to read through them all, so I'm just going to let people to read through them at their own time. We don't have to vote necessarily on those. We can tweak them, as Heather said, before as we work through them and with the community's feedback later on. But they're just to provide some sort of guidance around each of those data elements that would be nested within the main adverse reaction risk summary. Yeah. Yes, Kelly. Sorry.
Sure. I just wanted to comment on the discussions about criticality and where we've got high equals anaphylaxis and everything else is low or lacking a differentiation between severe and life-threatening, because I've also come across this in various places trying to get data sets that fit clinical real life. It is really, really dangerous to not differentiate between a serious reaction that is not life-threatening and a serious reaction that is life-threatening. Because if we only have one, all those patients who are, celiac, who might be in hospital for a week bleeding out of their bowels, that's not anaphylaxis, but it's really serious. And that level of reaction is actually quite important when you're making clinical decisions about how am I going to proceed with what treatment or what advice I'm going to provide or what care. So if we are having criticality anywhere we have a high, we need to have that differentiation.
If the clinician regards it as high, like you've just described, I think it's very valid for it to be high. But, basically anything that is just trivial potentially has a criticality in the next exposure. And we don't know without a crystal ball gazing about whether that's going to be anaphylaxis or not. Whereas if you've got something that has been a serious thing, it should be regarded as a high one because the next one is also likely to be high. It's not likely to get less if it's a true allergy. So it should be recorded as high in that situation, Kelly. I don't have a problem with that. It's not just anaphylaxis, but anaphylaxis is an example that nobody will usually argue with. It's the other things. It's really up to the clinician who is managing this to determine the high and communicate that to other people so they take it more seriously than just I'll just give it a try. Rather, it should perhaps be administered in ICU under steroid cover or something if you need to do it next time, that kind of thing. Does that make sense? Does that fit okay?
It kind of does, but it differentiates the treatment decisions that you would take. So if we're looking at data sets and data value, I do think there is value in separating out life-threatening immediate true allergy anaphylaxis type reactions from really severe we have to do other things, because otherwise you get, and we have this currently, a lot of patients who do have those things that some people call trivial. Oh, you just get a bit of diarrhea. It doesn't matter if you actually have basically gastro for 7 days. It's just diarrhea. That's a low criticality, right? So because it's not life-threatening. So I really do think in terms of how patients are managed, that this is super important. And I've spent a lot of time working with patients who, they get ignored, they get missed because this distinction in between is absent, and the way that it is structured in clinical information systems is those really, if there's only high, it will get reserved for anaphylaxis anaphylaxis, I beg your pardon.
I think, criticality is a good label, it's a good flag, but I think it should never ever be ignored compared to manifestation and the severity of each reaction in each event. And that's why it's important to record those. They actually should be the ones that are guiding any clinical decision. And of course, sometimes you might have a reaction event that's been filled out with anaphylaxis, and it's then the next time they get exposed to it, there's no reaction. That actually gives you the cue that, in fact, the substance may well be completely wrong. So I think criticality, is a label. It's kind of nice. It might help drive some decision support or some even just filtering on a screen, but I don't think it should ever take over from the actual manifestation and severity of reaction in each event that we record. That's actually where we're going to get our information for that decision making. So I don't think put too much weight on that criticality. I think the other is actually more important.
Sure. I just see the way that it'll be implemented is if you have a high level propensity to reaction against a substance, that's going to be what's going to get used rather than to search through each manifestation of an event to find the severity there. So for the purpose of clinical decision support, it's going to probably plug into the high level one against the substance rather than try and find each event severity.
We're talking about the user interface and how that presents it, and I think that's another level. There's some really good work that was done by Mike Bainbridge, who's living in Australia now, when he was working for the NHS, and it goes back to about 2010, and it's all pitched around the substance name, the manifestation, the severity, and criticality is a trivial thing by comparison. So that you're talking about implementations and how things are displayed on screens, and I totally agree with you. How that is presented is absolutely the most important thing, and it shouldn't be criticality at the top level that drives these decisions. It should be an indication, it should help us use things otherwise, but it's a supportive thing, not a critical thing.
Agree. Maybe this is a point that to go into the implementation guides, because I am struggling with a lot of technical side of people who will say, no, this is the high level. So just as a note.
No, just because it's at that root level doesn't mean it's actually more important than the details of each reaction. I totally totally agree with you. It's a matter of then how you display it, and that, you know, happy to share that documentation with you as well, because I think it's some of the best stuff that I've seen. But it's another issue to what the data model is itself. I see Tony's got his hand up, and we're really running close to time.
We've only got 3 minutes left.
Yeah.
We able to, yeah, I think if it's okay. I want to see, can we do a vote on this proposal? If you voted with minor changes, can you please let us know in the chat what that might be, so that we have an idea, so we can make sure we just take that into account. We'd love to know. So Tony, if you wanted to put your question in the chat, we can come back to you, because I think we've really got 2 minutes and I think people need to leave. Sorry, just timing. I think we've still got one left that we haven't got to, but we'll get to that at the next meeting. But yeah, if you either put it in the chat or send us an email, we'll make sure that we either address it directly if it's a question, or bring it back up if we need to. Okay. I'll just leave the voting thing up. We've still got head circumference, vaping summary, and medical devices. We'll bring that to the next meeting. We may need more time next meeting, but let's see how we go. Just in terms of next steps, the next CDG meeting will be the 17th of September. So we will continue with the priority backlog items, and we'll also try to confirm the scope of the outputs that came from the last face-to-face and bring them to this group here, and then work through some of those health assessment data groups. If anyone's interested, I don't know if people, I think it might be sold out anyway, but there's a technical connectathon next week in Brisbane, so hope to see some of you there. And then there's another CDG meeting in October on the 8th before our face-to-face in Canberra on the 12th. The tickets should be going out soon. We'll probably be working through some of the health assessment stuff, looking at encounter record and chronic condition management template. So kind of outputs of the last meeting as well. So you'll watch this space. The tickets will go live in the next week or two, I think. And that's all we had. So thank you so much. I'm not sure what time the next CDG is. If you can check it on the website, or Maddie may know off the top of her head. So thank you so much for all your time. Really appreciate it. If you have any other questions or comments that you would like to make, please feel free to email them. I think the chat will probably close down after this. Also, if you have any more forms and tools, we're keen to hear about those. So yeah, just pop us an email. We're really keen. And I'm so glad to see you back, Chris. Thank you so much for joining us. Really appreciate your time. So thank you, everyone, and have a good afternoon.
Thanks. Bye.
Thank you.
Thank you.